questions for you. Can you kind of give us a little more insight into the type of endoscope you use? Are you using a gastroscope or a colonoscope, and what size do you think that roughly equates to?
Yeah, I'm sorry, I didn't project well on one of those, but I typically, and I've used a variety of different sizing and bougies, and I've ultimately settled on the pediatric colonoscope. It's an Olympus pediatric colonoscope. It's a 38 French. I found that the gastroscope is, I think depending on the brand and which one you use, is in the low 30s. The standard colonoscope, I think, is 40 French, so it seems to be a good compromise, and it's worked well.
You know, and one thing that can happen that can make laparoscopy be more difficult is if you get a lot of insufflation in the small bowel. It decreases your working space. Do you find that by placing the endoscope, how do you help minimize the small bowel insufflation?
You know, I think I can't remember that ever being a problem. Typically, we come in and look at the stomach, quickly insufflate it, and then and desufflate it with very little overall insufflation. So I've just never seen that or experienced that to be a problem with significant small bowel dilatation.
You know, another thing that we see often is when we're dividing the short gastrics and resecting the stomach, sometimes we see that the portions of the spleen become ischemic and actually turn, you know, like a color blue when compared to the remainder of the spleen. Does that concern you at all? Or?
Yeah, I mean, I've certainly noticed it. I wouldn't say it's common, but I've certainly seen not large portions of the spleen. Typically, it's on the superior pole where you may see a well-demarcated area where it clearly looks less perfused than the rest of the sleeve. But I've never seen that translate into any clinical problem for the patient. I'm sure maybe if they had an early post-op CT, the radiologist may comment on it, but I've just never seen a complication from that, such as you know, an abscess or anything that was obviously abnormal.
And do you have any tips about removing the stomach from the abdomen? I know, you know, not placing it in a bag to prevent bunching, but sometimes, you know, you're trying to remove it from that incision and it feels like you're really tugging on it. And, you know, do you find that the infection rate would be any higher if perchance you were to tear the stomach when it wasn't in a bag?
You know, our infection rate was very low, it's less than 2%, but I think there are a couple tips. One is, it's one reason why you use a 15-millimeter trocar. It essentially creates an initial defect that's bigger. In almost all stomachs, we will put a Kelly clamp in and dilate the fascia so that it probably easily accepts your finger and almost two fingers. And then I'll reach in with a Kelly clamp and grab the first staple line on the antrum where that staple line reinforcement is, and it's a nice handle to kind of pull it up. We find that if you just rock the sleeve back and forth, I would say our average extraction time is probably easily under 30 seconds. And it's quite rare. I think in our study, the disruption rate or spillage rate was less than 10%. And interestingly, the patients that had a wound infection were in the group that had an intact stomach on removal.
And then one final question before we move on. What if you have a patient who has known Barrett's without dysplasia, who really wants to have a sleeve gastrectomy, you know, referencing the consensus paper that would be a contraindication? Would you still offer that patient a sleeve gastrectomy, and do you think there may be a role for pre- or post-operative Barrett's ablation with RF?
Yeah, I mean, I think that's a great question, and I think it gets to the point that there's no absolutes, you know, and I think in a patient that for whatever reason is not a good candidate, if they were on the fence, clearly I think I would use that to push them to a bypass, but if for whatever reason a bypass was not an option for them, I think the overall health benefits of them losing weight probably outweigh the relatively small risk that they would ever need an esophagectomy. And now with our new modalities to treat it, to treat the Barrett's, I think when you factor that all in, I think there are some patients where even in the face of Barrett's without high-grade dysplasia, that you could consider sleeve.
Quick panel discussion at the end. I think we will now move on to Dr. Dimitrios Stefanidis, and he will be talking to us about bariatric emergencies for the non-bariatric surgeon.
Good evening, everybody. Can you guys hear me okay? Keith? Can you hear me okay?
Yes, we can hear you, Dimitrios.
Okay, great. I just want to make sure because I just got in. So I want to thank again also SAGES and Dr. Gersin for the invitation to participate in this panel. I think it's an exciting one, and I think we've shared a lot of good information and lessons learned both from Dr. Sudan and Dr. Kuwada. I'm going to talk a little about bariatric emergencies. I guess both for the non-bariatric but also the bariatric surgeon, since at least I think the way things are going, a lot of these we end up seeing. But for the residents on the call, you will be in a situation that you're very likely to face some of this just because there's so many patients now in the United States who've had bariatric surgery that you're likely to encounter one of them at least if you're on call for an emergency room. And complications that you may encounter obviously may be early complications after surgery. And most likely if it is an early complication, it will be addressed probably by the surgeon who performed it, but you may be also in a situation where you may be covering for someone who performed it and may not be available. So you might have to deal with this. A leak typically will happen is either the gastrojejunostomy or the jejunostomy is likely something that you could see. Thankfully, these complications happen rather infrequently in our own practice. They've been extremely rare, and we've been fortunate. Bowel obstructions can happen early on as well as later. We'll talk a little more in the late post-operative complications because bowel obstructions typically do happen later. Infections, intra-abdominal or at an incision can occur, of course. Bleeding, endoluminal or extraluminal can happen, but most of the time the bleeding that does happen after bariatric surgery typically will happen within the first 24 hours and will be addressed by the operating surgeon. Deep venous thrombosis or PE do happen rather infrequently, mainly because we do prophylax everybody, and I think bariatric surgeons have been in the forefront of using prophylactic Lovenox or heparin, and we've been doing this for several years, and now it's becoming one of the skip measures. It has become one of the skip measures that everybody kind of has to do in surgery. But I think clearly this has helped us minimize the risk of deep venous thrombosis and pulmonary embolism. As you know, obesity, or as you may know, obesity is a risk factor for deep venous thrombosis. A number of patients get spontaneous thrombosis. Surgery, the early post-operative state is also a risk factor. So clearly these patients are at a high risk. And I think from the perspective of the general surgeon, what you need to understand is that this particular risk is not just relevant to post-bariatric surgery patients. It can happen to obese patients that you do a lap chole or something else as well. So they're the same risk, probably more so related to the duration of the procedure rather than the actual procedure. So this is something to know. You may encounter this. You may not have to do something much, but they may present to you because they're going to be early post-op. Pneumonias or cardiac events can also happen, but they're not very common. In regards to leaks, if you look at the literature, the rates tend to be low. In our own experience here at Carolinas Medical Center, our leak rate, both with the bypass and the sleeve, is about less than 0.1%. So they're very, very rare. Usually, if they do happen, they will happen within the first week. After a sleeve, these leaks tend to occur even later than that. And they're actually divided into acute and late leaks. But I personally am thinking that it may be more a late detection of those rather than a late occurrence. In my own experience, I did see a patient 5 months later to have a leak, which wasn't really a leak. I think it was a perforated ulcer. It was a patient that Dr. Kuwada was mentioning earlier, to minimize the chance of anastomotic ulcers after bypass. We tend to steer patients towards sleeve. This is what I had done with a lady who was chronically on steroids, was also taking aspirin. She still ended up getting an ulcer that perforated, and